morning, everybody, and we are going to jump into the neck, the pharynx, the larynx. We'll start off with going over some of the anatomical components, including boundaries of the neck. We'll talk a little bit about some of the key structures, viscera. I will omit the endocrine glands today because the next topic is going to go over glands. So I'm going to skip through a little bit of thyroid, parathyroid, and then we'll talk a little bit more about some of the key neck structures, including musculature. We'll talk about the structures of the pharynx, the smaller muscles inside the larynx, and the cervical spine. There's quite a few small muscles involved, okay? And that makes it tricky because some of these tiny muscles is not easily visible on a model. And if it's extremely difficult to see on a picture, I will generally not use that for the practical because sometimes it's a tiny little fiber set behind another muscle within the Adam's apple region of the cricor cartilage, and it's tiny. So it depends on the view, and it can be very tricky. And then we'll talk a little bit about drainage patterns of the neck, go over the neck's vasculature. So you're going to hear a little bit about nerves again. And hopefully you are not at this point sick of cranial nerves, because there's a few cranial nerves that do run the show. And then we'll talk a little bit about some of the, I guess, clinical applications or the end. Any questions? Okay. So it'll be kind of two sections. And then the only item that I'm going to skip through is the endocrine glands, because we're going to do that next Saturday. It'll be dedicated just for the glands. So our story begins for this week with a quick overview of the neck, right? So lift up your chin, look at your mirror in the morning, and you notice there's, bulges and structures around your skin, fascia, and then underneath that there's musculature. So we'll start off with a quick overview. This is a snapshot on the image on the right. You can see there's two views. On the right side, this is a deep view. Go ahead and circle this. This is the deep view of our neck region, and it includes bones. You have some plexuses, some arteries and veins, but mandible serves as the superior border, kind of the top frame of this picture. And then the bottom will be your clavicle, right? So you have the top and bottom, and then everything within it. We're going to go over some muscles today. Okay, so just like we did before, I'll give you a chart. As for the muscles, what you need to know is the key action, and also the key innervation. Some of these smaller muscles, like the omohyoid, sinohyoid, all the hyoid muscles, they're so small. Their O's and I's, I would say, are overlapping. And so it can get really tricky if anybody were to ask you just a question based on, oh, this bone or this structure got damaged, which muscle is compromised? You almost can't answer it by itself. You have to have another action involved or maybe a nerve involved. Okay, so for the muscle list for this topic, action, innervation. All right, pretty fair. If you want to impress somebody else, or if you want to be ahead, then you can look at some of the O's and I's, which is optional. So inside the neck, number one, the most important main blood supply is going to come from the carotid arteries, and then the main venous drainage is the jugular veins. What I did for this set of PowerPoint, and if you were here last Saturday, the slide deck was a little different. I put pictures on a slide by itself. This is the one that I traditionally do at the med school, where you have the image with the text. So it's a little bit more busy. When I do this, I'm going to highlight and key bold terms. Those are the items you should look at, because there's a lot of slides, right? You guys get a lot of content. Some instructors might give you a ton more material than others. And the benefit and really the mastery of teaching is just diluting the content so that when you come in, you know exactly what you need to focus on. Right? Versus if I were to tell you this stuff and you got to go and spend another 3 hours just figuring out what I went over. So anything in highlight, make sure you know. Okay, so whenever you're looking at my slides, anything in highlight, look at the image, make sure you remember what goes what. Okay, so carotid arteries and then jugular vein. Now the first section is going to go over some of the bone structure. We'll start off with a little bit on the posterior side of the neck, and we'll talk a little bit about the first couple of vertebrae. Okay, because C1 to C7 spans your neck region, and there are three of these special cases. C1, right, these stand for cervical, number one, cervical number two, that's called the atlas and dens. These are very unique vertebrae that maintain the base of the skull, and they form the ability to turn your head. The C1, C2, and C7, these three are unique in the sense that they have a slightly different anatomical variation. Even though they're all cervical, the C1, C2, C7, they generally will have a unique spinous process that tends to bifid. So what that means is if you were to look at the spinous process, right? So if you just take your finger and then run it back to your back of your neck, you'll feel a bulge. That's C7. Okay, so that tells you that's a C7. So everything above that is going to be C6, 5, 4, 3, 2, 1. C7 is that bigger bulge called the prominence, and then all of these generally will have, if you look on the picture here, a bifid spinous process. So you can see C4 compared to C5 compared to C6. Obviously, the biggest difference is that the body, so the body is this big round block, is going to get a little wider as you transition down, right? So the body is not visible in the atlas, C1. C2, the axis, this one has something called the dens. The dens is a protruded odontoid process, literally a vertical process protrudes upwards that forms a little ring. And then C3 to C4, C5, C6, you can see the body, right? Everybody see that? So I'll use another color to highlight, maybe a little easier. So the body's right here, the green, and that body gets substantially larger as you transition down. Okay. The other structures like the foramen and the transverse faucets, these are all overlapping. They're going to have these, but then C1, C2, if you were to see it in a bone box, or if you were to see these bones identified, isolated, you could clearly tell them apart, right? It might be trickier if you were to compare C4, C5. If you just have C4, C5, these two bones by itself, it's a little tricky, but it's based on the body size. That's usually one indicator. And then just kind of highlighting what I said is that C3, C6, the general trend is that they're going to have a small body. They're going to have this slightly more concave surface. And this is not a good picture because it's flat, but it has a concave surface on the superior side where it joins. And then the vertebral foramen tends to be a little bit more triangular shaped. Okay, triangular shaped than round. That's the definitive features. This is an example where if we, and I think actually, you know what, during the lab time HoloLens, I'll take a look and see if we have a model. I think we do at the base of the skull. Take a look at it. But this is an example where having a model or having a tangible item will make a big difference. Okay, so summarizing what I said here, C1, 2, 7. These ones are unique, special cases with the bifid. And then C3 to C6 generally will have a similar, smaller body, but progressively gets bigger. And then it has a concave, smooth surface on the superior side, and its vertebral foramen is more triangular. Okay, so if I were to ask a question and say, oh, there was a fracture that occurred in the neck, and the vertebrae, tends to have these structures, which of the following would most likely be damaged or injured? Okay, we good? So again, just remember the numbers. 1, 2, 7 is unique, and then 3 to 6 more similar. All right, cool. So that is your bones of the neck. A little bit more on each of the unique ones. So C1, 2, and 7. C1, also known as atlas, that's another name. So you could see a question where that name is interchangeable, but there is no body, and it has this two kind of kidney-shaped flat surfaces that groove onto the kind of the base of the skull, right? So it's right on the inner side of the mastoid process. But these two facets are what sit the skull on top, right? So it's a resting state, forms the atlantal axis joint. And then the vertebrae, or the one that protrudes upwards, is the odontoid process. This is on C2, also known as axis. This picture does not do a good image, but you can see this one right here where I'm circling. This will be a little vertical upward protrusion of a process. And then we have C7. Okay? The C7 prominence is the one that you can felt. In some variations, there could be some slight bifiding, but most of the time, it won't bifid. But that's also the biggest protruded part of the neck, right? So just remember that's a landmark for the back of the neck. And then on the anterior side, the key bone that we have is the hyoid. Right? Anybody remember what was significant about the hyoid? We went over the mandible, right? We went over the mandible and the facial bones, but we didn't really get into the hyoid. I just briefly said it resembles a small little mandible. Anybody recall what's unique about this hyoid bone? Does it have any articulations? No. Okay. It doesn't have any other bone that it's articulating or joint with. It's free floating. It's adhered by a series of suprahyoid muscles and also a series of infrahyoid muscles. As I'm talking, it's moving. That's also the bone that you would ideally want to compress on if you want to kill somebody. Okay, so if you're choking somebody, right, if you're trying to headlock somebody and you're trying to pass them out and try to, lethally choke them out, then you would try to snap that hyoid bone. That's the anatomical significance there, okay? And then Over here, it's suspended by the muscles, like we said, and then there are two little horns, a greater horn, that basically are formed and transitioned into fibrocartilage. I'll have a picture, but be mindful of these key bones of the neck, right? So there's only a few, not too many. So now as we go from the bones, I'm going to go to the tissue, the fascia, and then we'll work our way to the muscle, right? So the whole point is we're doing bones first. We're going to get to the fascia, then get to the muscle, then the blood supply, and then nerve. That way it covers all of the neck area. So the fascia is going to be the tissue layer, and this is a pretty cool image. If you zoom into the vertebrae, so the vertebrae is right here in the middle, shown in green. But right in front of it, you'll see that around, so it's kind of blockading between the vertebrae and also the anterior trachea, and then your opening of the mouth, and the oropharynx, nasopharynx. There's going to be a series of layer fascia, and this is basically a layer of fatty kind of tissue, that kind of boundaries, almost like a cushion. It lies between that dermal layer. But if you zoom into it, you're going to see there's actually quite a few layers. The outer fascial layer is called a subq layer. And then we're going to have 3 to 4 sub-layers that are deep within, right? So if you remember last Saturday's class, the theme of all of the structures of the body is there's layers. The tricky part as you're studying is you need to know which layer is considered superficial, which one is considered deep. And that depends on how you memorize it, right? So if you're looking at it from inside out or outside in. So I'm going to go over it from the outside in. I think that's just a little bit more straightforward. So actually, let me show you a better picture here. So the first one is your superficial layer. Okay, so superficial layer. Then we have the deep. I'll come back. And then moving from deep, we have the investing. And within the investing layer, you're going to have substructures I'm going to highlight. Okay, so superficial, that's going to be on the outside. Deep, and then goes in. You can also reverse the way of memorizing, right? You can also go from inside out. So that's really your preference. Within the investing layer, right, this is the first inner layer, you're going to have a couple of iconic structures that it adheres to. And think of this as like a membrane or a film that surrounds the entirety of the neck. So it's a barrier. It does attach to some key structures. So if some structures were damaged, let's say you snapped a bone, then you could compromise a layer, and maybe a layer could be ruptured. So some of the structures of the investing layer that touches include your submandibular gland. So that's your salivary gland. That's number one. And then on the superior side, I just made a list. You don't need to memorize every single one of these, as long as you can recognize that these are all in the neck area, right? So you have the hyoid. That's very noticeable. That's in the middle of the neck. You can see right here. The hyoid, I'll circle it. The hyoid. Literally, it's kind of an anchor, right? This is a solid bone of anchor. You also have the inferior border of the mandible, so the base of the mandible right here. I'm going to circle them. And then, by the way, the view you're seeing on the right is the sagittal view, right? Because this is the best you can do with the 2D picture. You cut the person right in the middle, and you look at what's being glued. And then the other structures will be the mastoid process, and of course, maybe parts of the cervical vertebrae as well. So you have a couple of positions that it can anchor. This is all superior. And then on the inferior side, like we just said, remember, whenever you think about the neck structures, just think the mandible is the top of the frame, and then the bottom of the frame is your clavicle. Right? Think of a picture frame. You have a top and a bottom. So the bottom, without even memorizing or looking at this, you would know that the inferior should attach to your clavicle, more specifically the acromion, right? That process that sticks out on the shoulder region. Okay, so that's the first layer. So that's your investing layer. This is the first layer of the deep layers. First layer of the deep layer. So last week we went over the parasotio, or remember the dura mater, arachnoid mater, pia mater. So you need to know which one's outer, which one's middle, and which one's inner. Okay, that's where the anatomy comes in. There's a little element of just memorizing which one is outside, middle, and inside. Okay, next layer is the pretracheal layer, so hence the term trachea. And this is another cool view. So it's shown here kind of like a little indigo, violet, purple color. So you can see right here it's highlighted. It's kind of nice. It surrounds the esophagus, food tube, and your trachea. And the key here is that this is going to originate pretty much from the hyoid again. So all of these kind of span the hyoid. Again, that's why it's free floating, but it has so much fascias and muscles adhering to it that give it support. And it also surrounds the entirety of the pericardium. Okay, so it's a whole film that kind of anchors to the heart. As far as what structures it can close, this is going to be mostly the trachea and the esophagus, as well as some of the infrahyoid muscles. We're going to get to muscles very soon. The word infra means below the hyoid. Supra means above. Okay, there's one exception that we'll talk about. generally the ones below it will depress the hyoid bone, and the ones above it will elevate. So as I'm talking, the suprahyoid will elevate that bone, raising it up. Okay, and there's a movement occurring. Okay, so this is, again, just the same thing as color-coded. It's actually nicely coded. I actually like this one. And then you can see on the right side, you have the fascia for the carotid sheath. This is important too. So you're going to have the carotid arteries and the jugular veins inside here. And then you have some lymphatics, and then you have that kind of prevertebral right in front, in light blue, right in front of the vertebrae. So these are obviously not color-coded in a cadaver. But when you're dissecting into the body, these layers will be teased apart, right? So it's like a layer on top of a layer. You're like, oh, this one comes right off. So it's like you're peeling it's like an orange, right? You have different layers or a fruit, and then some layers kind of disappear a little easier. So these are the layers of the neck region. Then the deepest one of them all will be the prevertebral layer. Okay, this is important. So of the prevertebral layer, it actually encompasses and includes the carotid sheath. So I'm going to put a star to this one. So everybody that's here, make sure you know what the carotid sheath is. This is an outlining surrounding boundary that includes the 4 key structures. Your vagus nerve runs through this. It runs through your internal jugular vein. It runs through some of the key sympathetic fibers, and of course the carotid arteries. So when you're doing an operation, or if you're doing some kind of surgery towards the neck, and doing some reconstruction, it's very important that once you get through the carotid sheath, you're going to get into the key structures, right? So it gives you a guide. Like, this is the boundary of what's really important. This is also why when you're doing surgery, sometimes if you just nudge or pinch the nerve, you will see reactions, right? Oh, you maybe went too deep, and then the vagus nerve got a little bit pinched, or maybe got compressed, and then you'll see the heart rate respond. Okay? So carotid sheath, super important. This is within the paravertebral layer, and it also does cover some of the neck muscles. I'm not going to stress out too much about these muscles. They're really small, but the scalenes on the lateral side, and then the longest capitis kind of more in the middle, but it does overlap some muscles. Okay? So this one is the prevertebral layer. Again, showing you the picture is right here, the kind of blue layer right here, and then the red circles you see is what overlines the carotid sheath. All right? So repeating myself again, make sure you know the carotid sheath. Okay? So it's very similar to, remember how we went over the legs? You have the femoral triangle, like that's the area that includes those vessels. This is the area that includes the key vessels of the neck. All right, you good? These are the key maps. So if you're still waking up, your computer, your brain's still dialing up, and you're kind of getting to kind of groove of the anatomy, circle or highlight, come back to that carotid sheath. Make sure you know the structures. Okay, cool. All right, and then next on the slide here, we're going to go into muscles. Okay, so the next couple of slides, we're going to now go into muscles. This is always the fun part. Talk about the action. You can always move them around and talk a little bit about the nerve. I think the nerves are what make it really exciting. You might not think that way, but I think it's important to know the innervation and how it's controlled. So first one's platysma. We talked about this briefly already. The broad, thin sheath, the muscle that kind of spans your base of the mandible all the way down to your clavicle. On the right, you can see that there's a couple of layers to it. There's a deep fascia on the inferior border. And then all the fibers, if you look closely, they run kind of top down, right? So they run parallel with the neck structures spanning down. The key item here is it's supplied by the cervical subbranch of cranial nerve number 7. What is the name of 7? Anybody? Facial. Really good. Okay, so hopefully you haven't forgot that. If there's one thing I've drilled with you guys is know your cranial nerves, know your alpha and beta receptors. What's actually funny is we had a meeting yesterday, and one of the other faculty was complaining that, oh, some of the students keep forgetting about beta receptors. You remember that? So every time I have you guys, I have a question on alpha receptors, beta. Alpha constricts, beta dilates. Where do you find these receptors? They're in your heart, right? Most of the blood vessels in your brain. These things you can't forget, right? Even though you hear it and you study for the exam, most of the time this stuff just goes right out. I know that too, because that's how I was as well. But there's some things you have to burn into the brain. Okay, and those are some things. So the things I generally go over: cranial nerves, your alpha beta receptors, some of the key muscles, some of the hormones. You got to burn that into your brain. Okay, all right, and then let's go to the next muscle. So platysma right there, straightforward. Okay, so this is a nice little list. This is a guide. Don't have to memorize this whole list, but on the right side, if you were to take your face and turn it to the left or right side, you'll see that there are different borders of structures that could be kind of, I won't say visible, but kind of denoted. Okay, and this is a good marking. So this is the different superficial regions of borders. So think of it like a Google map of the neck. If you turn left or right, and then you were to flex your sternocleidomastoid mastoid, some of these regions could be more prominent. And as a result of, let's say you're doing some sort of surgery, reconstruction, you're going to cut into it, remove a thyroid gland, or doing some sort of kind of invasive procedure, you can use these borders to kind of ideally know what's behind that structure, right behind that zone. So just going over the regions, you can see number 1 is on the bottom, 2 is showing blue, 3 is a little green triangle, 4 is a pink region right on the lateral border of the mandible, and then 5 is right below the chin on the mental region, 6, 7 is a gigantic red region, and then we have A and B. Okay, and then on the left-hand side, it's just some of the key structures within that area. Right, so if you're most of us, again, they're always genetic outliers. Letter A, right here, the orange A, this is the majority or the dominant body of the sternocleidomastoid. So again, you just turn your head, and then based on that map, the A letter is where the bulk of that muscle runs. Okay, this is just good information for you to know and kind of follow along. And then you keep your head over there. At the base of that muscle, you have number 1. That's going to be where you're going to have your internal jugular vein. So if you are ever curious, where do you find your vein, your jugular vein? Take your sternocleidomastoid and then run your finger to the bottom. That's where it'll be at. All right, so that's where you can find, and a really cool pulse if you're trying to find is that sub-branch of the subclavian third arch. So you can feel that, and it's on the lateral side of it. So that's why if you're trying to pulp somebody, or maybe be able to palpitate, maybe feel the neck or feel for any nodules, you know what region you're touching. Okay. And then letter B on the back side, the most lateral border here, this one is going to be corresponding to the trapezius muscle towards the back neck region. Number 2, shown in light blue, this is going to be where you're going to have, and I'll highlight this, the accessory cranial nerve. Okay, accessory, that's going to be nerve 11. And then number 3 is a small little green triangle, kind of at the midpoint between 2 and 1. And that triangle contains most of the hypoglossal nerve roots and kind of passageway for the nerve. Number 5, this is going to be where you have the jugular vein passage as well as submandibular gland. So if you're trying to find that gland, it's right at the bottom of your neck, your chin, right under your chin. And then number 6 is that little orange triangle right below number 4. And then that's going to correspond to your the carotid sheath that we just talked about, that kind of cover lining. And then the last one is number 7, which is going to be most of your hyoid muscles. Okay, so specifically sterno and sternohyoid. Right, those are 2 dedicated muscles in the gland. So if you were trying to palpitate usually if you have like a goiter or if you have a thyroiditis, a thyroid issue, the first thing a physician, a PCP would do is just to touch you. They'll take their hand, they'll palpitate around the thyroid, and that's usually right at 7. So you find 7, right, that region, and you take your finger, you just kind of feel it. And you usually feel for asymmetry or symmetry, right? So the left and right side are the same. One side's bigger, one side's smaller, and that's how you go. Okay? So this is good for knowing the positioning of structures and as a guide of map, right? Obviously, you're not going to be able to have a color-coded, model or neck. But you're going to have a sense. Okay, so the next one is the SCM muscle. We're going to abbreviate that as the sternocleidomastoid. SCM divides the neck into the front and the lateral sides. Key items to be mindful of is the action. Okay, so I said before, action, make sure you know them well. 2 key actions. It's going to contract, allowing extension of the head. That's number 1. And also the unilateral lateral flexion. So left and right movement, shaking your head. And then on the right side, you can see the picture. This is not too bad, but if you were to tilt your face down, left and right, shake your head, that's all the sternocleidomastoid. Okay, and you can see just the body, right, the thickness of that muscle. It's a pretty substantial muscle, and like we said, it's right in the middle. Right, the base of that, you have the jugular vein. Okay, that's how you find it. So if you were to ever, I don't know, maybe like if you're trying to kill a chicken or trying to strangle somebody, you know exactly where you're looking at, right? Because you might be thinking like, oh, there's a neck. Okay, obviously I squeeze the neck, choke them out. But if you know the precise location of where you're going, you could be more surgical, right? It's like more of a surgical, right? Exactly, and that's, I'm sure if you're into that kind of sports or MMA, I mean, that's a secret. When you're doing a headlock, like the position of what you're pressing on, and then you're going to cause the response real quick. Okay. And then as far as attachment goes, if you're curious for the O's and I's, I just listed it here for you. It attaches to the manubrium, mastoid process, and then the superior nuchal line toward the back of the occipital bone. So those are the key landmarks of the bone where they originate, insert. Recalling real quick is origins for any muscle means the site of least movement. The insertion is the attachment where there's a little bit more give, there's more stretching movement, and generally the compromise is the insertion, because that's where it moves. So if you were to ever damage a muscle or fracture the bone, if you compromise the insertion, then the muscle is gone. Okay, cool, nice. And then the next one that we have is on the posterior side of the lower neck. This is going to be trapezius towards the posterior cervical region. A few key items here is that it does originate attached to the pectoral girdle, also at the base of the cranium. So just think about where it's located in the body, and you can be able to describe it, right? So you don't have to memorize it word for word, but if you look on the right image, I'll give you guys a quick pointer. You can see it's a triangular shaped muscle, kind of a diamond triangular shape. This is only one side. It touches the acromial process of the scapula and also touches the base of the skull, more specifically at the superior nuchal line. Okay, so this is same thing where you have the nuchal ligament that allows you to raise your head. So there's a lot of sites attached to the base of that skull, right at the occipital region. The one little detail that I want to add is the action of synergizing with the levator scapulae to help elevate and raise your scapula, and also plays a role also to breathe. So if you were to, I guess, forcefully inhale and you're trying to expand and exaggerate the body torso, you could also recruit parts of this muscle. It also does work a little bit with the serratus on the lateral side to help you support the shoulder. So these are minor synergies and they work on the same side. So trapezius, serratus anterior, and your levator scapulae, they're all on the same side. All right, they have a synergistic meaning on the same similar action. They reinforce the same modality of how it moves. Versus an antagonistic will be the exact opposite. Okay. All right, so let that sink in. Trapezius. Summarizing what we said so far is in the lateral region, the key muscles that I talked about were the SCM, trapezius, and then over here, just notice that if you were to divide the neck region, and in case you're still a little lost in location, SCM is more anterior. Platysma covers over all of it in the front. Trapezius is on the posterior side. On the inferior border of the base of the neck, we have the clavicle, right? That's the bottom of the frame. And then on the top, we're going to have either the mandible or on the posterior side, the superior nuchal line. So just remember the frame that we're looking at, right? So if you were to zoom into the neck, you have this region. And there's a lot of precision and small regions that you got to be mindful of, especially if you're going to surgery or if you're trying to do manipulations or you're doing a neck adjustments, that kind of stuff. Okay, so here is the chart that I always will provide for setting the muscle. So when you see these, it's just for your information. Put this into a note card, or maybe put it onto Anki or however you like to study, but this is just a quick cheat sheet. What I would want you to know for sure is obviously the name of the muscle, the action, right? So platysma, the definitive action here is that it raises the inferior borders of the mouth and also helps you draw the skin of the neck upwards, okay? And in my questions that I will put on the quiz or the exam, I will generally use this verbiage, all right? I'll use this action. Depending on what you use, right? There could be a number of ways to describe this, but this is pretty fair. I've gone through quite a few anatomy books in my time, and I think this is pretty detailed and pretty fair. And it's similar to the medical one. So later, when you get to medical school, your anatomy class also is very detailed actions, all right? And then the last one, of course, you know it, is the innervation, the nerve, okay? So it's fair. So the O's and I's or the proximal distal attachment, you can just, if you don't have time to go through all of them, don't stress out about it. But definitely know that it's the cervical branch of the facial. Okay, that's a platysma. So please associate cervical branch of facial with platysma. Sternocleidomastoid mastoid, we already said that. Unilateral contraction of the head, tilting it to one side, as well as bilateral movement, so shaking your head. And then the key innervation is going to be your spinal accessory. The good thing is that some of these muscles overlap the nerves, right? So your job is to make sure which one's, the oddball. So in this list right here, platysma is the oddball. It's the one that's the cervical branch of the facial. The other two, trapezius, sternocleidomastoid, these are going to be supplied by the spinal accessory, nerve of 11, And then just like we said, the main function of these trapezius, not only to synergize with the scapulae and serratus, is it elevates, retracts, and slightly rotates your scapula. Okay, pretty fair? So try to keep it nice and simple for you. This is your superficial muscles of the neck. We're going to go now deeper. Okay, these are all on the outside. So the first layer would be these sets. Okay. Now, the next set that we have are deeper, a little bit more tricky. On the right side, you can just see how busy it is. Whenever you see these images, I'm not trying to overwhelm you with the list of structures. Just look for the ones I have highlighted in bold and just kind of have an idea of which one's deeper and which one's more superficial, right? Just there for you. So in the lateral cervical region, the ones that we're going to go over are the splenus capitis, the levator scapulae, the middle scalenes, and posterior scalenes. And sometimes the inferior one might just be kind of bulked and lumped together as the anterior one. So depending on what text or what image you use. So we'll go over the functions and actions of each of them. Okay. As far as arteries goes, this is quite interesting, right? You might just think, oh, you have the carotid artery, jugular vein, easy. But there are sub-branches and there's variation. Okay, so this is the part where there's going to be a little bit of nuance, a little bit of detail that I'm going to fine-tune. So we'll start off with the key arteries of the neck, right? So you already heard me talk about the common carotid, that's the main one. The subclavian artery, right? This is going to give rise to several sub-branches. And I want you to look at the picture. If you look over here, most of the time when you're pulsating for a strong pulse, you're usually going for that lower half, the lower third to sixth portion of your subclavian. Okay, that lower third part is what you're actually pulsing for. And that's clinically significant. So if you're ever trying to feel a pulse, right? Oh, you're actually trying to locate the lower third of that subclavian to feel that movement. Right here, you can see in most cases, the number 1 is going to branch to 2, 2 to 3, and this is where you're pulsing for. So this subclavian arch, where it curves over, is technically the longest region and the most superficial. So it's the closest to your skin. That's why you can feel the most. Other ones are deeper within. You wouldn't want to risk poking or snapping their clavicle just to be able to feel it. And then another mindful part is be mindful that the transverse cervical artery, this is a subdivision, does have the ability to bifurcate. And in some people, they might not bifurcate. So there is variation for some of these splittings. Okay, so right here I have highlighted or circled that the bifurcation is the cervical artery or the dorsal artery. Okay, there's 2 subsplits. These are the key differences amongst population. Everything else generally pretty common. Right here, just a nice image of the common carotid. Right, so very really noticeable, really big one. It goes into the internal common carotid, ascends up towards your head, and then right here you can see the splitting into the subclavian, the 1, 2, and 3. Okay, so just be mindful that the third part of your subclavian is what you're pulsating for. That's the most superficial region. There's one thing you need to remember is that's the part. The third part, not the second part, the first part. Okay, and then moving on, for the vein and the key drainage, pretty straightforward, your jugular vein, more specifically your EJV, external jugular vein. And this is going to be kind of the curvature towards the base of the mandible. It's deeper to the platysma, but the key part is that this is going to drain for most of the upper limb. It does have a juncture at the brachiocephalic vein, so let me show you the picture. So right here, it's a little hard, but if you see right here at the bottom, there's a bigger blue brachiocephalic, and the juncture is going to be right at the EJV, so EJV comes down. Right, so let me use another color. I'm using blue again. I don't want to use red because it's going to overlap. So right here, if you follow the orange, there's a juncture right here, so the EJV connects into the brachiocephalic, and so generally, a question that I could put in, or how this could be put into question, is which of the following gives rise to the brachiocephalic vein? Right? So what's the one before it? Okay, before it. So that would be usually, you look at your choices, and the most straightforward one would be EJV. There are some smaller ones, like on the picture here, you have the anterior jugular vein. These are most tiny communicating branch. Some of these could be variations. So generally, if there are variations, I won't put that on exam. Because just remember, there's like 10% of some populations where this one branch goes a little bit different, or this one branch does not split. But the main ones are all the same. Okay, so we covered the arteries, veins. Okay, now let's talk a little bit about nerves. So nerves is always a big part in my discussions and my presentations. So for the cervical region, the key nerve that we'll highlight is your spinal accessory, cranial nerve number 11. This one passes deeper to the SCM. There's several plexuses that give rise to this region, okay, and I do want you to know them. We went over the brachial plexus already, right? Remember, we went on the upper arm. You went over this with Dr. Richards. So just quickly kind of highlighting the significance of the passage is that it's going to route through that first rib, passes through your clavicle, and it goes and innervates directly to your upper arms. Okay, that's the route. But within that region, you have your subscapular nerve that is a branch of the brachial plexus. So that's a division of it. So if you're looking on the right and you're just kind of following along, there's different roots, obviously, and sometimes it could be tricky. That's why it's color coded. So the orange color right here are the cranial nerves. You have the 12 and 11. And then the green ones you see on the image here, these green lines, these represents all the sensory fibers that come out from the base of the skull. And then the purple ones and the anterior ends are all going to be motor based. Right? They go with the muscles. In the cervical plexus, you're usually referring to C1 and C4. Okay, that's the span of the range. And then the key sub branches that control your diaphragm and the main subdivisions of terms, and I'll have it on the next slide, is your phrenic and the ansa cervicalis. I know I went over some of these already, but when I did go over them, I just told you this region of the skin that it supplies. Remember that? I said, oh, ansa cervicalis, that's kind of the upper ear region or this zone. So it has sensory function, but now we're going to talk a little bit about the motor functions. Okay, so we're just adding a little layer. So the next slide is super key. So I'll put a star here with a lot of highlights. A lot of sub nerves, you need to know the number. I do not have a cool number code or a mnemonic for this one. You can maybe play around and see and create something. But the first sub branch of that lateral cervical region in the neck is the ansa cervicalis. Okay, this is also roots of C1, C2. Okay, C1, C2. The key structures that it supplies is going to be your hyoid muscles. I'll highlight them: the infrahyoid, the omohyoid, sternothyroid, and sternohyoid. Okay, there's two of these: sternothyroid and sternohyoid. There's 6 muscles. There's a digastric one. This one only has 4. Okay, so it's not all the muscles. It's only 4 of them. And this is a sub-branch of your hypoglossal nerve, cranial nerve number 12, ansa cervicalis. Okay, so we didn't go over the muscle supply last time. We only talked about the skin. I said around the ear of the skin, the base of the skin of the temporal region. So this is very important. And then as a small detail that's kind of tricky is that the thyrohyoid gets an independent sub-branch directly from the hypoglossal. So that is a slight difference and variation. And so if you were to look at the picture, if you look really closely at it, you'll see the C1, C2. Again, the routing could be tricky, but this is right here, the auricular nerve branch. This is the sensory distribution for the skin. In the middle, you have the sub-branches. Again, it's not perfect, right? Everybody could have variations of where it branches and how the nerves kind of innervate the zone. And then the second one is the lesser occipital nerve. Pretty much generally just only sensory based, so your skin and your scalp. Then we have the greater auricular nerve C2 and C3. Okay, so you need to know the numbers, C2 and C3. This is going to supply your mastoid process, the auricle, the flap of the ear, and of course the mastoid base of the skull. Okay, so those are the zones. Then we have the transverse cervical nerve, C2 and C3, the overlapping. So this is where it gets tricky because there's overlapping, the roots. The anterior region. We have the supraclavicular nerve, C3, C4, the shoulder of the skin. And then the last one is your diaphragm, basically, the phrenic nerve. C3, 4, 5, keep the diaphragm alive. That's like a rhyme. So C3, 4, 5 at the bottom. That one's going to help you for breathing and the diaphragm muscle and the skin around that region. If you're looking through this, the way I always like to kind of approach it is just go from C1 to C5, right, top down. Okay, so going from top down, ansa cervicalis is first, lesser, greater, transverse, supraclavicle, and then phrenic on the diaphragm. So you're just working your way from top down. Okay, you could also go from bottom up. All right, so just make sure you know the names, the roots, and definitely know what it applies. All right, so in the exam or quizzes, easily I could put like 3 or 4 questions from this slide alone. Right? I'll just ask, oh, you know, there's a patient that comes in, and then for some reason the omohyoid, sinohyoid muscles have lost their action, and there's no ability to raise the hyoid bone. Which of the following nerve roots are most likely compromised? Right, and then you'll have like author C1, C2, L1, L2, T1, T2, and your answer will be C1, C2. Okay, so that's how I'm thinking of it. So this one's an important slide. Okay, so please, for those that are here, put a star to this. I kind of indicated with the highlights in the bold terms. That's super important. I think it hopefully helps because at the medical school, what we kind of a good practice is to tell them which slides are high yield, right? I'll give you the slide deck. There's like 50, 60 slides, but out of the 56 slides, maybe there's 20 of them that are high yield that you can spend more time on. That's the benefit. Okay. All right, cool. Any questions? I'll pause it there for a second. Any questions at all? We feeling okay? You guys awake yet? Okay, cool. So just let that sink in. There's quite a bit of stuff. Okay, so let's take a moment, and now we're going to transition to the anterior region. Okay, so we went over the lateral side. I talked about the muscles. I went over some nerves, briefly covered some of the blood supply already. We're going to work our way now towards the anterior superficial region, just kind of talking about some of the general superficial structures. So the anterior region, this is going to be the facial, face front anatomically positioned look at the neck. The boundary, if you think about a picture frame, right, the lateral boundary and the superior boundary, apex, right, so on the top you have the mandible, right, like a little picture frame. Lateral side, you're going to have your circulated mastoid. Right? If you're drawing like a little box around this frame, you kind of have a picture frame, right, and then what goes in there. So right here, this is a good view of showing you some of the hyoid muscles. It gets kind of tricky because they're really small, and earlier in the beginning I said that on a picture, I generally won't use the hyoid muscles for identification because they're so small. But you can see the hyoid bone being the equator. So if you were to use this color, if you use the black line as the equator, there's a set of muscles that are above it and a set of muscles below it, right? The mylohyoid above it. Digastric, there's a posterior and anterior belly. This is the biggest one. This is kind of the most noticeable one of the suprahyoid muscles. Then we have the omohyoid, sternohyoid, sternothyroid, right? So when you're looking at the positioning, you should definitely know which ones are below the hyoid bone and which ones are superficial and which ones are more midline. Okay, so take a look at it, right? The fibers they're kind of overlapping a little bit. It's hard to see it because you got to tease them apart. But in this picture, you can clearly see that the mylohyoid, digastric are sitting above the hyoid, right? These two are above. And then these three are below. Okay? These three are below. So that's number one. So make sure you're aware of which one's above and below. So within this region, you'll see a couple of key zones. These are all referred to as triangles. Okay? So the triangular kind of region is a pretty common boundary for most anatomical bodies and blood vessels, lymphatic drainage nerves. It's a nice little frame, divides the area into a specific zone that you can know what's behind it. So we'll go over a couple of the key zones of this anterior cervical region. Right? This is all superficial. This is all on the outside. The first triangle is when we refer to as the submental triangle. All right, so you should know the term. Mental is towards the chin. Sub is below it. A triangle right below the chin. So the key structure is this is going to be forming the base or the boundary of your hyoid. Okay, so I'm going to use that term. So in an exam question, I'll say the patient's submental triangle, right, was compromised or something in there was not in the right position, or he got injury and there's a damage over there. The second one is the submandibular triangle. This is going to include the mylohyoid muscle and also some of the tongue muscles, the hyoglossus muscle, as well as some mandibular gland. Okay, so that's the second triangle. All right, and it's not that hard because the term or the first word of describing the triangle tells you already what's there. Right, so submandibular triangle, you're going to have the salivary submandibular gland, and then we have the carotid triangle. This is going to encompass that carotid artery. Don't get confused by the sheath. The sheath is a layer of membrane within. This is superficial. Or we're talking about the outside now. We're not talking about the inside. Within that triangle, you're going to have the carotid sinus. This is, why didn't I highlight this? This should be highlighted, but this is a key structure. I'll just go ahead and put a star to it. But the carotid sinus is what houses the dominant sets of the baroreceptor for pressure sensing in the blood pressure. Right? So you may recall this from the cardio and the physiology that there's a lot of baroreceptors that measure the blood pressure, right? Aortic bodies, carotid sinuses. That's where the bulk of the baroreception occurs. It's within that carotid sinus. And then the carotid body is a chemoreceptor that picks up the change in the CO2, mostly monitoring oxygen, so it can change the rhythm of the heart for moving the blood and then your breathing pattern. Okay? And then the last triangle here is going to be your muscular triangle, and this is going to include the infrahyoid muscle and the thyroid gland. All right? So just be mindful of the triangle and be mindful of which structures are underneath that zone. Let's take a look on the right side. So you can see over here, this is kind of dividing the borders. Bless you. Real quick, digastric, there's two bellies, anterior belly on the front and then posterior belly on the back, right? Again, some of these images are easier to spot because they're different layers of the hyoid muscles. And then on the bottom, you have the sternohyoid right here. So this is a little bit more anterior. And you can see the sternocleidomastoid mastoid. Okay. So again, it's not showing you every single muscle. On the bottom of that image, you'll see right here, there's the carotid sinus and carotid body. These are literally a bundle of cells in the blood vessel that have that receptive function. Right? So it's right in that sinus region. Okay. All right, let's take a quick break, get some air, pause, do some squats, air squats if you need to. Get some water, recharge, move around. We'll come back. We're going to go over the hyoid muscles in a second, and then we'll talk a little bit about the cartilages. We got to go through all the cartilages of the neck. That's not. Okay, all right, so before we took the break, we went over the anterior cervical region. We went over the key triangles and mapped out what are the key structures that are underneath those zones. Right? This is significant because as you're looking at the neck fascia, you can get some insight on what structures are beneath it and what could be compromised or injured if a zone or region was damaged. So within this region, the key muscles are the ones that are above your hyoid or the ones below it. Right? So suprahyoid are a set of muscles that have a general function. So as you're memorizing the action, this is your cheat code, okay? Anything above the hyoid generally will elevate the hyoid during speaking or swallowing. That's key action. Raise the bone up. Anything infra is going to depress the hyoid bone and larynx. However, there is an exception, okay? Just like with most of the stuff, there's like this one odd one. So just showing you the picture, there's two views. We have the superficial view. This is a good image, by the way. So on the left, we have superficial, shown in the left side. And then on the right side, we're going to have the deep view. All right. The difference here is in the superficial view, just the outer surface, you'll see the mylohyoid, stylohyoid, and digastric. These are key muscles you'll see the first layer. On the infrahyoid muscles, you'll see the omohyoid and the sternohyoid. On the right side, the ones that you cannot see above the hyoid is the geniohyoid. This is the one. So put a little star to this. So deepest suprahyoid muscle is your geniohyoid. That's the one that is underneath the other sets. And then as far as the infrahyoid muscle goes, it's going to be your thyrohyoid right here. Some of the fibers might overlap, so that's why you see omohyoid, sternothyroid on both sides, but thyrohyoid is the one that is deeper on the infrahyoid side. So total, right, about 7 of these muscles. There's 4 on top, 3 on the bottom. Digastric should be the most noticeable one because that's 2 bellies, 2 full bellies. There's an anterior portion and one on the posterior side. Okay, so be mindful of that. Make sure I'm recording. We're good. All right, and then let's go into the muscles. Okay, so this is the cheat sheet for you for the key muscles. Again, I'm going to just stress that the O's and I's or the proximal distal attachments very much overlapping, very similar. So if you look in the third column, generally all inserting to the hyoid bone and generally all starting from the mandible. Right? That's your general rule. Don't worry about that. Definitely know the action. Okay, so look over here. Out of all the muscles inside the suprahyoid muscle, which one is the one that also depresses the mandible? Digastric. It's the biggest one. It has 2 bellies. It's a little bit more unique in the sense that it has ability to pull down on the mandible, whereas all the other ones are just slightly elevating the hyoid. It's very small motion, so you can barely even see it. If you're talking and swallowing, you'll see it kind of flap a little bit. So just a real quick going over the action. Digastric elevates your hyoid and also plus depresses, let me just underscore this one, depresses the mandible. The geniohyoid, which is the one that's the deeper one, right? The deeper one of the 4 set, elevates your hyoid. The mylohyoid elevates your hyoid, and your stylohyoid elevates your hyoid. On the right side, you're going to have the innervation. And there is going to be also slight variation. Digastric is going to come from predominantly V3 and facial nerve. Okay, because there's 2 bellies, there's 2 branches. Okay, so that's the one that you want to be very mindful of. Okay, this is such a big muscle. It's almost like 2 muscles. Honestly, they could easily have characterized this one as 2 muscles, anterior being 1 part and belt and posterior being 1 part. Geniohyoid is the hypoglossus. And then trigeminal V3, again, this is going to be for the mylohyoid and then the facial nerve cylohyoid. Okay, so this part, there's just a little bit of memorization that you're going to have to put in just to know which one goes which. Okay? There's some overlap, and there's some nuances, some differences. Okay, so this is the set that are above it. All right, so again, make sure that gastric, you know, this is the unique one. Now we're going to have the cadaver image. So I haven't posted the full cadaver image yet, but for the suprahyoid, infrahyoid muscles, this will be the image I will use for the practical. Okay, so I'll tell you right now. So this is the image that you want to look at. Just like all the time we have it, the left side is going to be superficial, the right will be deep. It's not color coded, but this is pretty good. It's a masterful dissection. You can see it very clear. So you can see the omohyoid very clearly, right here. I'll trace it out for you. Omohyoid, sternohyoid right here. Digastric right here, the anterior belly, very visible. And then the only one that's kind of tricky to see is your stylohyoid. This is kind of small right here on the circle, the lateral side. Mylohyoid right here. Okay, so again, this is not perfect by any means, but it's pretty good. I generally will pick the one that's more visible. All right, so a tip for you, just looking at the image, right? This one looks, you guys see that? Stylohyoid, super small, barely visible. It's kind of blocked by the mandible. I probably won't use that. It's a little bit tricky, arbitrary. I'll use the one that are clearly, you can see the whole fibers, you can see the span of the entirety. Sounds good? All right, so this is the cadaver image. I'll upload it on Brightspace, a separate document, right? Like the 3 slides or 4 slides of the cadaver. Did I share this with you guys before? I feel like I did. The neck one. Did I show you guys the neck muscles when we went over the facial muscles? I feel like I did. I'll double check because when I posted the cadaver images last half of the class, there was a couple of slide decks where I gave you a chunk. And then for the exam, I trimmed it down. So it might be in there. If not, I'll just post the trimmed version for you guys, okay? Cool. So the next set of muscles, right next to them, are going to be your infrahyoid muscles, and then we're going to have the main 3, 4. Sometimes when you're grouping these together, I tend to like to group the sternohyoid and sternothyroid together because they're very similar sounding. So I like to kind of slash them, like sternohyoid, sternothyroid. Even though they're separate items, they're kind of in one unison. Reason why is also on the right side. If you look on the innervation, they have the same innervation. So both sternohyoid, sternothyroid, they are both innervated by C1, 2, and 3, the ansa cervicalis. And generally the function is to depress. Okay, so there's so much overlap. That's why I group them together. Omohyoid is a little bit bigger, more noticeable. So this one depresses the hyoid bone. Also C1, C3, 2, C3. Right? So omohyoid, sternohyoid, sternothyroid, these 3 are generally all this. This should be pretty straightforward, right? It's depressing the hyoid, raising it down. C1, C3 are the supplying. You don't need to worry too much about the O's and I's again, but if you need to know kind of just a ballpark zone of where they attach, if it's below the hyoid, that means the superior border would be the hyoid, right? It's below it. So what's on the bottom border of the neck? What's the frame? What's the bottom frame that we just talked about? So on the top, we have generally the mandible, right? That's the top frame. What's the bottom frame? What's the bone? Clavicle, right? So basically, you're going to think, and what's in the middle region? Your chest plate, right? Chest plate, sternum manubrium, right? So that's the border. That's kind of the bottom half. And so if you're thinking, oh, this is a set of muscles below the hyoid, that means the hyoid is on top, the superior border, and on the bottom border, the bottom of the picture, would then be your manubrium or sternum. That's it. So you don't have to memorize it. As long as you know if it's below or above and what's around your neck, you can describe it. What you will need to memorize is probably the nerves. Because you can't just guess that from looking at the face, right? You need to know either C1 or C2 or C3. So again, C1, 2, and 3 are for omohyoid, sternohyoid, and sternothyroid. And hypoglossal cranial nerve number 12 is for the thyrohyoid. Okay? So those are your 7/8 key muscles of the hyoid bone. You know those. And then going from there, there's going to be the anterior subdivisions of the blood supply. And we're going to talk a little bit about the carotid artery. So there's 2 divisions of the carotid artery. There's internal and external. The external actually has 6 sub-branches. Okay? There's a subdivision. They sub-branch into different regions of the cranium, parts of the orbit, the scalp. I'm not going to require you to know the names of all sub 6, but just know there's about 6 deviations that comes off of that. However, the internal carotid goes straight up to the brain. That one has none. That then forms the basilar, the circle of Willis, the base of the brain. There's the circle of Willis, anterior, vertebral, paravertebral, communicating arteries. That's going to be directly up to the brain. Okay, so just be mindful. Internal carotid, no branches. However, the external carotid, there's 6 sub-branches. Okay, be mindful of that. The right common carotid eventually splits into the right subclavian, whereas the left common carotid ascends the neck. Right? So the left and right side are not symmetrical, not evenly distributed. Okay, and if you look at the picture, you'll see right subclavian curves over, and we talked about that already. The third half is what you're pulsating for. Right? That's most superficial. And then you have the carotid artery going up. The external is the one that has 6 divisions, right? And if you look at it, you can trace it around to the occipital artery, ascending pharyngeal, posterior auricular, and the internal one goes straight up to the brain. Okay, that goes to the brain supply. The circle of Willis is the base of the skull. So here are the names. However, I'm not going to require you to know the specific names. Just know that there's a medial, posterior, kind of an anterior zone, right? So you're dividing it to the front and the back, lateral side. It's good to know, but as far as question goes, I'll probably throw something where, which is it external or internal that supplies this area? Okay? Because there's deviations. If you remember the names, it might not be the case for everybody. And the medial one is going to supply towards the middle ear and also the cranial meninges. That's all I want you to know. The posterior one is going to supply the posterior region of the scalp, like send posterior to the back. And then the posterior auricular is going to be towards the auricle, the ear, as well as parts of your facial and parotid gland. Okay? And then the last one would be the anterior region, which is subdivided to the thyroid, lingual, facial arteries. That's going to be all the infrahyoid muscles, sternocleidomastoid muscles, SCM. So for a question, what I'll ask is I'll just ask something pretty straightforward, like, hey, this patient comes in, this person somehow has no blood supply or it's got occlusion of the blood supply to these muscles or these regions. Which of the main artery supplies this? And then you should know the answer would be the external carotid, not the internal carotid. Okay? Sounds good? So I'll probably throw like 4 or 5 choices, but the answer would be external carotid. That's the main one that supplies all these muscular features, all these glands, nerves, that area. All right, cool. And then over here, just showing you that picture, same thing again, so you can see it's not perfect, but you can see as it goes in, the first section, right? So 1, 2, 3, 4, 5, 6. It's kind of like 6 sub-branching that comes off. All right, cool. And then now the vein for the anterior region is going to match with the internal. So we went over the external EJV. Now we have the IJV, the internal jugular vein, drains all the venous passage from the brain, from the anterior face, all the viscera that we went over, and of course, majority and all the muscles of the neck. So I didn't list them out, it's just muscles of the neck. They then merge down with the subclavian vein and then eventually commit to creating the brachiocephalic vein. So just know the passage. So internal jugular, subclavian, brachiocephalic. Right? So know the different stages. These are pretty big ones, so I think that's fair. To know the sub-branches, again, you don't need to know the sub names, but they go into the facial, lingual, pharyngeal, thyroid. They actually overlap with the arteries, but there's only 4 sub-branches for the veins, but there's 6 for the artery. Okay, so that's the difference. So there's a little bit of asymmetry. Right? We just went over, I just showed you 6 for the internal carotid, but for the internal jugular, there's only 4. Okay, so not everything is nicely balanced and everything is evened out. That's the unfortunate part. Right here is a picture showing you external jugular vein, smaller branch, and internal on the inner side. We have those sub-branches like thyroid vein, right? You can just map it out, occipital vein, the facial, pharyngeal, and some of these sub-branches, these variations, that's why it's not worthwhile to memorize every sub-branch because of the deviation in the population. Okay, so as far as nerves goes, this is where we have revisiting to the cranial nerves, right? So you remember the mnemonic that we shared. We talked about the motor or sensory or both, and also the names of those nerves. So just over here, the key nerves include hypoglossal. We've talked about this a few times today. Cranial nerve number 12 supplies your intrinsic of the 4 muscles of the tongue and also directly comes from C1. Glossopharyngeal, number 9, is supplying the tongue and the pharynx region, and then, of course, vagus. That gives rise to your pharyngeal, laryngeal, and cardiac branches. Okay, so those are the 3 key cranial nerves that will have passages through the anterior cervical region. On the right, you can see just a brief tracing. It's actually 3 different colors. So you have the green, right, shown here, the spinal accessory, the green one. And then we have that kind of purplish color right in the middle. And then on the front, we have the glossopharyngeal. Okay, so those are the 3 main cranial nerves that run past this region. If you were to damage the muscle, and there's a risk of pinching one of the nerves. Okay, so as far as the viscera of the neck goes, and this is a little bit on the overlapping with the endocrine, I'm really quickly going to go over the layers. I'll go over this again next Saturday, but because of your thyroid gland being right in this center region of your neck, and you have the parathyroid gland on the back, there is a membrane that surrounds this gland. Right? Everybody should be mindful that the thyroid gland is a butterfly, so it looks like this, a little butterfly gland, right at the midpoint, right below, about an inch below your cricoid cartilage, or Adam's apple, and you can palpitate it. When your thyroid is overworking, or if you're depleted of iodine, or if you're thyroiditis, you have an inflammation or nodule, that can lead to a swollen thyroid gland. And that is indicative of either the deficiency, either endemic goiter, where it's iodine not in the body, you're not eating enough iodine, or you can just have antibodies tagging onto the cells and causing it to flare up. But that gland is surrounded by the endocrine layer that surrounds that kind of coating layer. And then around the larynx and the trachea, we have the respiratory layer. And then around the esophagus, we have the alimentary layer. So around each of these tubes, there's a membrane that cushions it. It's not just hanging right behind the muscle. Okay, that's the only significance of this. Okay, so now the last part of today's talk is going to be solely on the cartilages. I'll go over the pharynx, larynx. Talk about the vocal box very briefly. Talk about the glottis, epiglottis, the cartilages. You need to know which ones are paired and which ones are singular. Okay, and I'm pretty sure I'll double check before we start the whole lens. I have a couple of models, maybe with the trachea, and we can take a look at it. But it's important because these cartilages are tiny. Like the corniculate, the cuneiform, these are tiny little cartilages on the posterior side. And on a picture, you can barely see them. Okay, so make sure you look at, I think we might even have it on the whole lens, but just take a look at the visual and then be mindful of how they look. So this is the start of the visceral region of the larynx. This is the vocal box. So as you're talking and phonating, this is right located at C3 to C6. This is a region where there's the vocal folds, vocal cord, and what happens is they tighten. These tiny muscles will tighten up as the air passages through, creating the ability to make sounds. Okay, so it's the windpipe passing the air through, and then you have this little cartilage vocal box that's stretching. This is located right at the middle layer of the laryngeal cavity. So if you look at the picture on the right, you'll see the epiglottis. This is the flap that covers over, right, your trachea so that food doesn't lodge in, pushes down when you're swallowing. The esophagus is anterior. It's slightly more compressed, right? So if you look at the esophagus, it's compressed. Trachea is always open. In order for the trachea to be maintained open, there are rings. They're cartilaginous rings that surround it. Those rings generally will change as you progress down. Some of these are C-shaped, some of them are full loops. Okay, and it's important because you got to have air going through at all times. If you collapse the trachea, then there's no passage of air. So right at the lip of the epiglottis, you have the glottis. Right below that, we have the cricoid cartilage, and that's your Adam's apple. Okay, the cricoid cartilage is your Adam's apple. That's what you can feel. There's receptors for testosterone in there, so it responds for usually males will have more prominent cricoid cartilage Adam's apple because of the receptors of testosterone. Over here, just a few items to point out. The ventricle is going to be a smaller recess in the laryngeal cavity. The saccule, this is going to be a little pouch with mucosal tissue. The glottis is key. So this is the ring on the upper top called the rim of glottitis. This is where the vocal folds can squeeze the air and pinch. When you have laryngitis, right, you lose your voice, oftentimes infections can swell that region, causing you to lose your voice because the vocal folds can't pull anymore. So you can't make the pitch as the air is going through. How it tightens is how much air gets to pass. Here's a visual, so let me show you a picture. This is on the right, four kind of states of the vocal box. Letter A is when the vocal box is kind of at a resting calm state. Right? So what you're looking at is you're looking at cartilages. The rim of glottitis is this kind of fold in the middle that can open up and span as air passes through. All of this stuff are ligaments and cartilages. Right? So those are the solid structures that pull and get stretched. You'll see this web of fibers called the conus elasticus. This is a set of film that basically maintains the vocal ligaments, and that's right in the middle. When you're breathing and forcing air in, this will pull and open up. When you're phonating and trying to make a sound, it will compress, and then air will squeeze through, and then a sound gets made. Okay, so that's how it looks if you were talking and it's moving around. So as far as the range and pitch goes, just be mindful that when you have a voice that can sing, a long range is based on the thickness of the fold, right? So if you have really good range, you can hit those high notes like Adele, then you have a thicker. And then if you have a higher pitch, that's based on also the tension and how much you're pulling. That can be trained. So when you're training to sing opera or to sing a certain kind of a genre of music, your pitch can be trained based on the vocal folds. All right. So that is just a little bit of the structure. Now, the key items are the cartilages in this region, right? So the first thing you'll see, and we talked about the hyoid bone already, there's the lesser horn, the greater horn, but this is the superior border of this snapshot. And right below it, you're going to see this membrane that attaches directly to the cricoid cartilage. Okay, you guys just see the cricoid cartilage right there. And then the cricoid ligaments is located right below it. So you do need to know that this is a set of very small structures, and they have ligaments that adhere one to one. The ligaments that connect them are going to be always the structure that it touches, right? So cricoid ligament touches the cricoid cartilage. On the bottom, you're going to see the cricotracheal ligament. So again, just using the words together, the cricoid and the trachea, right? That's the ligament that joins each of them. On the bottom here, this tube is called the trachea. This is the air pipe. Notice on the posterior side that this is a C-shaped ring. Right? C-shaped ring. So that means it's always open. You can't compress it fully down. As you go down, transitioning to the smaller, there's going to be less cartilage, so there's ability to dilate, constrict in the airways. Now, the two views I want you to look at is not the anterior view, but the view is the oblique view and the posterior view. Okay, so the only view you can see those cartilages is this view right here in the middle, or a slightly slanted oblique view. All right. Can you guys see how small the cuneiform and corniculate are? Okay, so those are tiny little oval-shaped cartilages that span right at the base of the epiglottis. I literally circled it in a black circle. Tiny little two sets. As far as identifying them goes, all I want you to know is if they're paired or single. That's it. If you have one of them, or there's two on both sides, one on each side. Super simple. Largest is your thyroid. Within the overlapping of the cricoid cartilage is the laryngeal prominence. That's your Adam's apple structure. That's the region that has receptors. And then there's epiglottis that covers over. And then the paired ones are going to be your ardentinoid, corniculate, and cuneiform. Those three are pretty much invisible from an anterior view. They're also slightly invisible from if you have like a view that's not fully turned around. If you have it slanted, just slightly oblique, you can't see it. You have to get a posterior view to see them. Okay, so those are the three unusual ones. So on an image, just be mindful of that. Which ones you can see, then those ones you can identify. If you can't see them, then it's not going to be on the choices. Okay, so again, thyroid cartilage, cricoid cartilage, epiglottis. Thyroid and cricoid are overlapping, so that's generally like the Adam's apple region. Epiglottis covers over, and then the base is the glottis, and then we have the ardentinoid, corniculate, and cuneiform. So within this region, you're going to have some super small muscles, even smaller than kind of the omohyoid or sternal-hyoid muscles. But these ones are going to be the external laryngeal muscles that move up and down and kind of support that entire structure. But these in general are going to be just, as a name was called, the intrinsic laryngeal muscles. I'm not going to put a name to them, but all these intrinsic ones are going to be supplied by cranial nerve number 10. Okay? Intrinsic ones. So that's one note to be mindful of. If you look on the right here, you can see they're all super small, right? These tiny fibers and tiny little fibers that kind of wrap around. They're so small that it's hard to know exactly if it's one set or they're overlapping. All right, so just be aware of that. So here is a list of the muscles. I'll probably just highlight two out of this list. So I don't want you to bluntly memorize everything and forget everything. So the two that I would probably say you could fairly see clearly on an image will be the first one, the cricothyroid muscle, This one plays a role for directly stretching the vocal cord. So going back to what I said earlier, training to be a singer, you want to know how to sing certain pitches. This is the muscle you develop. Right? The more you sing, the more you go over, the more you tighten that muscle, the more it gets defined and controlled. This one's going to have attachment on the thyroid cartilage. It's so small that it's hard to see where it inserts to. So I just listed that one structure that touches. And then as far as innervation goes, it's cranial nerve number 10. Okay, so that's the one. So I'll put a star, cricothyroid. I think this will be a fair game on the selection of choices. And the second one that you could fairly see clearly is on the posterior side. You turn that trachea around, is the posterior cricoartentinoid. Okay, this is the one that will abduct the vocal folds. Abduct. So remember, the vocal folds are two lines, right? They can either open up or go in. Okay, so this is the one that opens it up, so more air can pass through. Okay. And then the overlapping innervation is cranial nerve number 10. All right. So out of this list here, only those two I think are a little bit more visible, and those are the two that I'll use for the quiz or the exam. All right. So I'm not going to just give you the whole list and say anything goes. Sounds good? So cricothyroid muscle and the posterior cricoartentinoid muscle. Sounds good? All right. Cool. So we're narrowing down the scope, or I'm focusing you to what you need to know and what's the most important. And now, of course, in the larynx itself, there are tiny little blood supplies that provide nutrients to the muscle and to the region, and also providing drainage. And we haven't talked about lymphatics yet, but we'll briefly cover that. But as far as the arteries goes, the laryngeal artery is your main branch. It has a couple subdivisions. There's superior, inferior. What I want you to be mindful of is the superior division is going to supply the cricothyroid artery, and then the inferior goes into the inferior laryngeal. So these are the two that are universal. Then the sub-branches might have variations, but the superior thyroid is going to give rise to the cricothyroid artery, and the inferior thyroid gives you the inferior laryngeal. So just look at the map here on the right, inferior laryngeal. These are super small, by the way, right? You can see that? Super small. Superior laryngeal. Here we have the superior, right? So you can see it goes down and then goes into the small one. The thyroid artery, right? The big one comes down and it goes into a small, tiny little vessel. Okay, and that's it. So I think as long as you can remember, superior goes to cricothyroid artery, inferior to the inferior laryngeal. And that's it. So for a question, I'll just ask something along the lines where, which of the following gives rise to the cricothyroid artery? And I'll have superior thyroid, subclavian, inferior thyroid. Generally, whenever there's a question on the blood vessel, you always want to answer the immediate one, right? Because they all come from the aorta, right? They all come from the aorta, so that's all right. But which is the immediate branch? So in the question, I'll specify which of the following is an immediate branch that gives rise to this vessel. Does that make sense? Everybody still with me? So the immediate one, not like the one 3 steps above it. Okay. All right, cool. Any questions about the arteries? Are we good? Anything about the cartilages? So just as long as you know they're paired or single, I think that's fair. And as far as nerves goes, the cranial nerve number 10, the vagus nerve, supplies majority of the larynx region. You're going to have 2 sub-branches that come out of this, and they match perfectly with the names of the arteries. So you get the superior laryngeal artery and the inferior laryngeal artery. Pretty good to know. As far as knowing the specific structure that supplies to, because I didn't ask you to know all 6 muscles, I didn't have anything in bold on the slide. Okay, just as long as you're mindful that the vagus nerve gives rise to that superior laryngeal, inferior laryngeal, and hence the larynx and the vocal box region. All right, now the trachea. So the trachea has a couple of features that we're going to briefly highlight. This is right at the level of C6 vertebra. There's going to be tons of fibrocartilaginous rings that support it, maintains this open posture so that air can go right through, transports the air, moistens the air, humidifies the air, and eventually is going to be the lateral on the side of it is your common carotid. Right? So it's a passageway that's a hallmark of the neck region. And then as far as the key structures goes, is you'll see on the right that there's the nasal pharynx region, right? This is the upper border, the oral pharynx region, the coronopharynx region. And this is a pretty cool view because it's actually teased open, and then you can see the bottom is the thyroid gland. So this is the superior aspect. As long as you're aware that each of these 3 zones of the pharynx has a slightly different function, the nasal pharynx is simply just for air filtration. Right? So the submucosal layer collects the air, moistens, traps any kind of debris and particulate. The oropharynx has a slightly more overlap with the alimentary canal, so breakdown of food. And then the larynxopharynx is going to be where the air passes away from the vocal box and going down the trachea. And that's it. As long as you know that there's 3 divisions inside the upper pharynx region. And you're good. Now, as far as the tonsils goes, these are just lymphatic tissue, like house it within here. So you have the lymphoid masses. A couple of these kind of zones to be mindful of is the palatoglasses and then the palatopharyngeal arches. These are the ones on the side. And sorry, it's too small here. You'll see the arches on the side. And then you'll also see the base of the skull. And this right here, you can see it's actually cut off. Actually, this is not a good image. We'll use another one. But over here, you can see a kind of a sagittal view of the tonsillar branch of the artery. So these are super small, and then the palatal tonsils on the upper left. All right, so just be mindful of the lymphatic tissue that's housed in this zone. Okay, so let me jump to a muscle set here. So this is a good view. So this is a view that I actually wanted to move to an earlier slide, but this is showing you some of the constricting muscles of this pharynx region. Okay, and on the left-hand side, you have a lateral view. On the right side, you have posterior view. It's very busy. All you need to be mindful of for the constrictors and pharyngeal muscles is that there's a superior, a middle, inferior, and that's it. As long as you know the superior is the most top, middle is right at the region of the thyroid and the cricoid cartilage, and the inferior will be kind of toward the base of the cricoid cartilage. And you're good, right? So it's circling inferior pharyngeal muscle, middle pharyngeal muscle, and superior pharyngeal muscle. I have the cheat sheet as well of the 3 muscles. I'm going to show you that. Right, so I just got to make sure I be fair. So we have, sorry, this is not the right side. Next one. The pharyngeal muscle. So we have the 3 muscles that constrict the pharynx: superior constrictor, middle constrictor, inferior constrictor. Okay, names are super easy. If you think about the action, literally there's no memorization involved. They all squeeze down on the pharynx to kind of compress the oropharynx region, nasopharynx region, or the larynxopharynx region. I also said that the O's and I's are so hard to decipher that don't stress out about any of the origin or insertion, but you do need to know the nerve supply. Okay, and then fortunately they're all overlapping with the vagus nerve and the pharyngeal flange. So I think that's fairly straightforward, right? So it's not too bad. The way I group the muscles up, if you look at today's talk, is I did the superficial neck muscles. I then did the hyoid muscles, infrahyoid, suprahyoid muscles, and then we did some of the constricting muscles. Right? So you have 3 sets of muscles. If you were to lump them together, it's a lot of stuff at one time. And it can be very confusing. But if you group them up and then put them or memorize and study them in a set, it's not that bad. Okay? All right, so let's do a question. I can see the fatigue in your guys' eyes. So let's do a couple questions, and then we'll come back to fill in the blanks if needed. Okay, so let's start with the first one. So you can stand, stretch, talk with each other. I'll give you guys a few minutes. So please log in the top hat, so that way I can see your progression. Yeah.